Hi, Dr. Talani is here from Ontario School of Osteopathy. I'm just going to explain about the normal gait and the common gait abnormalities. When we are analyzing the gait, the normal gait, we have to consider one gait cycle. There are two terms that we have to consider. One is called the heel strike and the other one is the toe off. So the heel strike is the moment that your heels are, one of your heels is touching the ground. This point is called heel strike. And the toe off stage is the moment that your toes are taking off the ground. So this moment is called toe off, and this moment is called heel strike. One gait cycle is the time, starting time from one heel strike of one of the legs until the heel strike of the same leg in the next cycle, starting the next cycle. So one gait cycle technically starts from this point, and then the person continues. Please don't look at this leg, just focus on this one. So until you continue walking until this point, the whole the stance is called one cycle of gait. When we look at this cycle of gait, so from this point starting until we come back the same leg to this point, there are two parts, there are two steps. The first step is from the start of heel strike until I put all the weight on the right side, and then continue walking, and until I am removing the weight from the right side, which is the toe off. This stage, from this point to this point, is called the stance stage. This is the part that I put the weight on one side. So this is the stance stage from this point to here. The moment the toe off starts until I continue and go to the heel stance, heel strike of the same leg, this is called swing stage. So the whole gait cycle for the right side has two parts. One is the stance part, and the other one is the swing part. I'll repeat again. So from here, the stance starts, stance, 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 and then here, swing, 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 and again the new stance starts. Normally, for the normal gait, about 60% of the gait cycle is the stance stage, which is the time that I put weight on one side, and about 40% is the swing stage. So this is something that you have to consider. So when the person having the normal walking, you ask them to just have a bare feet, and ask them to walk 5 to 10 steps forward. You stand behind them, you look at them, and then ask them to come back. And you consider some of the key points for the gait. You just think about, you just look at each side, you see okay, the heel strike, toe off stages is it at the same time? Is it symmetric or is not symmetric? You look at the hip. You look at the hip to see if the hip is level or not. The tilt of hip about 4 to 5 degrees, and also rotation of hip about 4 to 5 degrees is normal within the normal gait. But if it's more than that, if it's too much tilt to one side or too much rotation to one side, that is considered abnormal, and we will discuss about it shortly. So the levelness of the hip is something important you have to consider. The trunk and also the shoulders considered to be in the same level the whole time of the gait. So you look at the trunk also, you see if the trunk is tilting to one side or not. You look at the shoulders, you see the shoulders are still in the same level and they don't move. There is no unleveling of the shoulders. And then the head is in the center or not. These are the major points we consider during the normal gait assessment. Shortly, I'm going to show you the common abnormal gaits that you will see in the clinic. Here I asked our model Mata to just help us to evaluate the normal gait. So what I do, I ask her to, with the bare feet, to just walk away from us and then come back. Just have the normal gait, try to be relaxed and the way that you walk normally. And then just go like about 5 to 10 feet away from us and then come back. So just repeat this. While she's walking, I look at the feet first of all. I look at the toe off and heel strike stages. I see if both sides are symmetric or not. And then while she's going away from us, I look at the hip levelness, which I don't see any abnormal rotation. I don't see any tilt here. Then I look at the shoulder levels. I see if the shoulders are staying in the same level or not, any rotation in shoulders, any trunk rotation. And then I look at the head level to see if there is any tilt or rotation in the head and neck area. The other thing we consider is the swinging of the arms, which supposed to swing symmetrically on both sides, which for her I don't see too much swings. So which would be the style of her gait. But if I see one side there is a restriction in swinging of the arms and the other side is normal swing, that is considered restriction on that side. While client is walking and we look at the gait, if we have any asymmetry in some area, that usually is due to two reasons. It's either because of restriction. Restriction means because of the tightness or because of pain in some areas. Client has restriction on one side. That causes asymmetry. Or it could be because of the weakness. If you have weakness in some areas, that might cause also asymmetry. I'm going to show you in this video right away the common abnormal gaits that you will see in the clinic. I'm just going to go through the common gait abnormalities that you will see in the clinic. The first gait that you will see is called slap gait, or they call it steppage gait. The steppage gait is the same as a slap gait, but it's more severe condition. So the slap gait and the steppage gait, both of them are due to the weakness or the full paralysis of the tibialis anterior muscle. So if this muscle doesn't work because of the muscle weakness or because of the nerve damages that go into this muscle, so you're going to have the foot drop condition. But while client has foot drop condition, cannot hold the foot in this position, what happens is during the gait that the foot will drop and will hit the floor. That's why we call it a slap gait. So what happens, the client, let's say on the right side, the client has this weakness. What happens anytime the client lifts the foot from the floor, the foot goes to this position, drop position, and then after, when the client want to just put the leg back, it's going to be like very fast is happening, and that causes the sound of slap. So technically the client walking like this, and you can hear the sound of that. So the client goes back again like this, and then that's it. You can hear the sound. The steppage gait is the same type of gait, but it's a little bit different. When you have the full paralysis of this muscle, if you have the complete nerve damage, not partial nerve damage, for example, and then this the foot drop condition is completed. There is no weakness here. So in that case, what happens is while client is walking, the toes are just scratching on the floor, and you can hear the sound. So you don't have like that the slap sound. What you have is like this. Client is walking like this, and then sometimes you hear the slap as well. But this is like more like this condition that the toes are kind of scratching the floor. So this is called a steppage gait. So a steppage gait and a slap gait are kind of the same, very similar. The next common abnormal gait that you will see in the clinic is called Trendelenburg's gait. Trendelenburg's gait or lurching is the gait that is caused by weakness of the abductors of the hip, which mostly are two muscles here, gluteus maximus and minimus. The thing is that the action of these two, gluteus medius and minimus, so the action of these two muscles are holding the hip in the horizontal level while you're walking. For example, when in the normal gait condition, when I walk, when I lift this foot from the floor, since there is no weight, there is no leg supporting this side of the body, you expect the hip to drop. But this never happens in the normal gait. The reason is that gluteus medius and minimus of this side, they become tight and contracted, and they hold the hip in the same level. So while you're walking, the hip doesn't tilt this side because the gluteus medius and minimus of this side are holding the hip. When you lift the other leg, the gluteus medius and minimus of this side are holding the hip. Now just imagine you have weakness of these muscles. If you have weakness of these muscles, let's say on the left side my gluteus medius and minimus or abductors of the hip are weak. When I lift the right, on the left side is weak, when I lift the right leg from the floor, because these muscles are not supporting my hip to hold my hip, what happens? My hip will tilt to the right side. So the moment I lift my leg, this side goes downward. When this side goes downward, because my body doesn't like me to fall down to the right side, my trunk will deviate to the left side to hold my body in balance. So this is what you are noticing. While Klein is walking in Trendelenburg's gait or lurching, you don't really notice the hip tilt, because as soon as the hip is tilted to one side, the trunk or the body will deviate to the opposite side to hold the balance. This is what you consider or you see in the gait when person walks. So the person, if the trunk is deviating to the left side, that means the muscles on the left side, the abductors are weak. So again, if this side is weak, the hip will tilt to this side, and then the trunk will go to the other side to keep the balance. So if I see this person is walking, usually what happens is the person is, the trunk, when I look at the body from the front or from the back, I see the body deviating to one side and coming back to the center. One side, coming back to the center. So what happens, just say we have a weakness of the left side, so this person is walking is like this, coming back like this, and then walking like that. So if someone has weakness of both sides, which is not very common, so technically you see the body deviating to one side and the other side. So technically become like this, which that's not very common, but usually we see unilateral condition, which is one side going like this and coming back. This gait is called lurching or Trendelenburg's gait. The next gait that is again common you see is called hemiplegic gait. Hemiplegic gait is seen in patients who went through a stroke. The stroke is the damage of the brain on one side, mostly the frontal lobe, that's causing the damage of the motor functions. So whatever side of the brain is damaged, usually the opposite side of the body going to the paralysis. We call it hemiplegia, that causing the hemiplegic gait. What these patients do, the position they have, mostly the flexors of the upper limb are tight, so they are like in this position. Let's say if the right side is hemiplegic. And then the extensors of the lower limb are paralyzed. So what they do, they are like this position, and then the knees, they cannot flex the knee because extensors are tight. So they are in this position in normal standing, but while you ask them to walk, what they do is, because they cannot flex the knee, they move the leg in a circle position and then just go to the next step. So what they do, technically they do this position. If you see the patient like this position, like this, with this gait, this is a typical gait of hemiplegia. That is the gait that is, you can right away say this person went through the stroke. And even you can say what side of the brain is damaged. Usually it's the opposite side of the side is you see the paralysis. The other side, if you notice, if you put like like if you block this side of the body, you don't look at it, the other side totally has the normal swing and normal walk. This walk is called hemiplegic gait. The next abnormal gait that you might see commonly in the clinic is called diplegic gait. Di means two, and plegic is paralysis. So diplegic usually is referred to the paralysis of two legs together. If someone has the full paralysis of two legs, including the hip area, usually they become wheelchair dependent, so you don't really see them walking, so there's no point to consider the gait. But we're talking about the patient who has paralysis of the leg area, like the lower limb, and then he's not able to flex the knees, but the hip muscle is still functional, so this person still is able to walk with the hip flexors and extensors while the legs are not functional. So this person, usually the way you see the diplegic gait, this person is flexing the body forward, like leaning the body forward to keep the balance, and then moves the legs like a backward like this to push the body forward and continue the gait. So these patients, if you see them, they're like this. They usually move the chest forward again to keep the balance again. So legs are back, the body is forward to keep the balance. So these patients, they walk like this. If you see in these patients, usually this is the gait. It's called diplegic gait. This is the gait that usually, if these patients, they have two legs paralysis. That is common in the damages of a spinal cord that causes the damage of from one point of the spine and lowers. There is full paralysis of the rest of the lower part of the body. So this is called diplegic gait. The other very common gait that you will see commonly in the clinic is called antalgic gait. The word algia means pain, and the word antalgia means no pain. This is a common gait because for any reason client has pain in the ankle area, knee area, thigh area, or the hip area, the person doesn't like to put weight on that side leg. So because of preventing this, the client doesn't like to have the long stand stage, and he would prefer to have the longer swing stage. If you remember, we talked about the stand stage is the time that you put the weight on the side, that leg. That's about 60% of your normal gait cycle, and swing is about 40%. These patients, they try to reduce the stand stage as low as 30-40%, and they increase the time of the swing stage that there is no weight on this leg. So these patients, as you see, like this side gait is kind of normal if you have pain on the right side, for example. So, but the right side, you just try to shorten the stand stage. So this is the way you see the gait they have. It's like this. They go like very short leg like this, and then they just walk like this. This is called antalgic gait. It means the client trying to prevent the pain. So this is called antalgic gait. Usually this gait is just telling you as a general information the client feels pain on this side, but this doesn't tell you the pain is in the ankle, knee area, or hip area. It could be any of them. It could be multiple points. So this is called antalgic gait. The other gait, we call it ataxic gait. The ataxic gait is the gait that is caused by the damages of the cerebellum at the occipital part of the brain. So cerebellum is the area of the brain controls the balance, equilibrium, and then if the person has the damage of this area of the brain, they usually have the ataxic gait. Ataxic gait means lack of balance, or they call it wide base gait, because these patients don't have balance. They usually keep their feet wider to keep the balance. What they do, these patients, that they always feel that they're falling down, and then before they fall down, the other side of the cerebellum pulling the body to the opposite side to make sure that to make sure that keeping the balance. So this, and then holding the right gait, as I said. So this, they go like this, they go like this. This is like a typical gait. Also, you see in the patients, they have, they just drink alcohol, like toxic alcoholic patients also have, because alcohol will have toxic effects in cerebellum and then blocks the actions of normal actions of cerebellum. That is, this is called ataxic gait, or it's called wide base gait. The other gait that you will see commonly in Parkinson's patients, this is called Parkinsonian gait. This is the gait, or we call it hypokinetic gait. The client has very short steps and slow, fast and short steps. The reason is that in Parkinson patients, they have very tight muscles and the movements are bradykinetic, means they are very slow movement. They have adapted themselves to have the gait while they have these small amount of movement and tight muscles. That's what they do. They just usually, again, move the body a little bit forward, lean it forward to keep the balance, but they have very, very short and fast steps. So these patients, and they have a position of the neck a little bit forward. What they do, they go like this. This patient have a very fast and short steps. When they want to turn to one side, they cannot turn the whole body. They have to use these short steps to be able to turn to one side. They go like this, and then turn, and then they continue have this short step. This is a typical gait in Parkinson's patients, or we call it hypokinetic. On the other side of the spectrum of the hypokinetic movements, which is a small amount of move, they have a gait while they have a little available movement, is a hyperkinetic movement, which is the typical gait is called choreiform gait. The patients, they have chorea, they usually have involuntary movements, and these involuntary movements, while they have gait, they continue to have these involuntary movements in the trunk or in the arm or in the legs. These involuntary movements doesn't cause them to fall down. Usually the client is still keeping the balance, but has all these movements. So you see like client is dancing, but all these movements are involuntary and not under the control of the client. So these patients, they usually have movement of the arm and the movement of the body. They just continue like that. They have all these movements, and then they stop, and then after they just turn back like this, and then they continue. So this is a typical gait for hyperkinetic gaits, or we call it the choreiform gait. I hope you enjoyed the illustration of these common abnormal gaits that you will see in the clinic. Thank you.